One thing that Kelly and I have noticed over the years is that feeding challenges are rarely just one thing.
It's multifaceted for sure.
A lot of parents, when they come to us, they usually ask for just that one thing. Like, what is that one thing that is so difficult for them to eat? Is it behavior or is it anxiety or is it sensory? But then we also realize that it is a combination of several things. And that's why Kelly and I love collaborating with each other on this intensive feeding program, because we think that with our training and our experiences, we can supplement each other really, really well. We're trying to look at the child from different lenses and try to help them through a multidisciplinary approach. So let me ask you first, because you came up with this idea of collaborating with me. So what was your thought back then?
Well, I think what you said is very accurate. There's a lot of times different pieces of feeding difficulties. And where I have had education and training and courses, there are some gaps, such as more in the behavioral realm and just how to even just more engage a child or get some reinforcements going, which we don't always use for feeding, but just to help make the environment more pleasant for the child. Because when a child's regulated and when everything is, I want it, maybe the word fun isn't good, but when everything's more comfortable for them, then everything runs more smoothly. And there's a lot of times that speech or OT and things like that don't have as much training in the behavioral world. So I thought if we could kind of like mesh our skills, then the child would be able to get the benefit of having both of us.
Yeah, and I think that it was a brilliant idea. And then when you proposed that idea, I was like, yeah, of course, I would like to try this out, because I did have several clients who struggle with feeding. And, you know, when we did ABA at the center, the parents actually brought food to us and asked us to help train them to try the new food. It's not my scope of practice. I'm trained in behaviors, but not in feeding. So at the time, I thought I didn't know what I was doing.
Exactly. We've all felt like that. Yes.
So coming back to the fact that we are looking at the child through different lenses, right? When you and I come together to do this intensive feeding programs, we always start out with an intake, an
Mhm,
assessment. And that intake will requires an in-person, a parent interview, and in-person interaction with the child. And
mhm.
our questions that we ask parents are always very different. So why
Yes,
don't
we
we
do.
start? Yeah. Why don't we start with you first? What kind of questions you ask?
So the questions I usually ask are more along the lines of let's look at the swallowing and chewing function. Let's see, what kind of textures they're doing. Let's see if they can progress to different textures. Let's see if there's a chewing problem or maybe they're pocketing food, holding it in their mouth. Maybe they're doing something like a tongue thrust where they're pushing food out and we need to kind of retrain a swallow. So it comes from a little bit more of a perspective of the functionality of how a child's eating. Of course, there's going to be aversion and refusal, but we kind of approach that more from the behavioral side. And I think you kind of ask the parents more about, what does that behavior look like and how does it impact feeding?
I do not have the training in understanding oral motor skills, looking at the child chewing the food and identifying what kind of motor deficits they have. But what I do look at is the behaviors around mealtime. And the kind of questions I ask parents are, what kind of behaviors? Do they tantrum? Do they drop? Do they flop? Or do they run away? And what happens when non preferred food is presented? How long is the behavior?
Mm.
What do you do after behaviors occurs, right? Or what do you do before that behavior? So all of these questions are very important so that we can prepare the environment to be more appropriate for the sessions with the child. And each
Yeah.
child, as we know, is very different.
All so different.
Yeah.
It's not a one size fits all for sure. And I think to your point, for example, the oral motor piece, if a child is having a refusal or a behavior because they're scared because they don't chew well, I think it's really important that we both explain our parts to each other. So you might not have seen the oral motor piece, and I might kind of be explaining, well, they're probably refusing because they're scared to chew. But even that being said, once we discover that, I don't always know how to help that behavior, even once I do start being able to teach them how to chew. So I think that's where we really overlap and cross over a lot.
hmm Yeah, definitely. I think one case that comes to mind is where we realize that the issue isn't just the deficit in or motor skills. It's also underlying issues as well. And do you remember that case of the little child? And we realized that the ultimate goal, of course, was to get the child to eat more food, but we have to address the medical issues or the anxiety piece of it as well.
Yeah. And I think that child that you're referring to in particular, that child did have a lot of medical issues before we even started that obviously contributed to his overall development. But he also did have quite a attachment to mom. And which is fine. All kids do, right? But it was hard to even get him in our clinic without some really big meltdowns, for lack of a better word. And we had to really learn how his relationship with mom was affecting his ability to work with us and was affecting his eating. So that was a really big part of it. I think we had to work for a while on just getting him so comfortable with us before we were able to even really interact with him and start working on some of the concerns that we had with feeding.
Because our intensive program is designed for 6 weeks. And within that 6 weeks, we have goals. But then, we tend to be very ambitious. We do want the child to eat a lot of food. But when we do this intake, we realize that, oh, the goal has to be more realistic. Yes, we want them to eat more food, but we need to step back a little bit and create smaller goal in
Mhm.
order for it to be more achievable for the child. So the goal
Yeah.
for that specific child was to be comfortable with us first, to the point that they would take a bite from us other than mom.
Exactly. Because we're not able to teach them anything new or introduce anything new if they're not even comfortable playing cards with us. There's just no way to bridge that. And like for example, the most recent girl that we had go through our intensive program, we had goals for her. But when we did the intake, dad had let me know that really I mean, she's older. She was over 6 and she only drank from a bottle. So the goal of eating typical food by the end of the 6 weeks was pretty unrealistic. So at that point, I told dad, hey, our goal for her really is to get her to be comfortable with like an empty spoon in her mouth. That was the goal for just the first couple weeks. Just because when you're starting at that point, there's no way to go from bottle to food without all the steps in between. And when she got anxious, it was your behavior training that came in to help her get more regulated while I was working on teaching her, hey, this is how we put a spoon in our mouth. This is where we put our tongue and everything like that.
Yeah, that will bring us to the next conversation. I want to talk about what happens in our sessions. It's
That's
really
a good
fun.
one. It's fun. It's different every day.
I feel like every moment in our feeding session is a learning opportunity. There's never a dull moment. And whatever we do, everything we do is very intentional and strategic.
Yes, it is. And I think that that would be surprising to some, maybe to see how playful it is, how we're
Mhm.
moving all around the room and sometimes all around the clinic. Like it's not just somebody, this particular girl that I'm talking about most recently, she had a history of needing to be restrained when the parents fed her because of they needed to get calories in her. Let's be honest. They were just doing their best, right? So another one of our goals was teaching her like, hey, you can eat and still have fun and come to the table and sit, take some bites and go play. And that helped keep her regulated and kept sessions moving in a really fun way. So that was another goal for her. And I think people would kind of be surprised to see our sessions like that, honestly.
A lot of parents have an idea in mind that we would just put them into a specific training programs, and after sometimes in the training they will magically eat the food.
Right.
But in real life it doesn't happen that easily.
It doesn't.
And we have heard so many stories that parents share that in other feeding programs, they would strap the child into the chair and just try to push food into their mouth, which can be very traumatizing for the child.
Yeah.
And that's definitely not what we're doing here.
No.
We always, interact with the child first to see what their comfort level is, and then we build from there.
Mhm.
I'm very happy to see that your approach is very similar to my approach. We always try to make the child feel comfortable enough to come to us. Most of the time, they will come to us. They will be happy to come into the clinic. Some other time, it takes them a few sessions, but it's never a problem. They come
Mm-mm.
into the clinic, they play with some toys, and they are happy. And that is the baseline, the foundation for a successful session.
I think so too. Because also, I think it's important to remember we can I'm sure there are programs, and I know there are programs you can strap a child in and you can get calories in. That's just the, we're able to do that. But that's not really teaching them at all to have a positive relationship with food or really want to eat. That's a miserable experience. So we want to think kind of too what our goal really is for them. Is it just calories, or is it kind of reframing our thinking around eating in a relationship with food that's a more positive one?
We want to try everything, right? We want to try if they are able to take a food from the spoon or if they are able to sit at the table to eat. Those are some really, really good goals to have, but we do not always start with them sitting at the table to eat the food just because their body don't allow that. They want movement. They may have some aversion toward the table. Maybe table means uncomfort. And that's why they stay away
Yeah.
from the table.
They know that that's like food, or maybe I'll be restrained, or maybe I'll be whatever it is with their history, we don't always know. So I think that that's really important to remember. I do like that goal of being at the table, just because that makes life easier for parents, that makes life easier for everybody, and that's where we eat, right? But for some kids, that's just too lofty of a goal to start with.
Hmm. And we start with them eating on the floor.
Yeah. Yes. Exactly. We've done lots of floor feeding.
Hmm. Playing and eating at the same time. When they feel more comfortable, they will be willing to try some new food
In sessions, there's a lot of play, there's a lot of music, right? We have sometimes if parents are okay with it. Sometimes we use screen time. There's a lot of movement. We have some other cool things in our clinic that kids tend to like. Our big like canoe that kids can get in and we can squish.
options.
We have a lot of fidget toys that can really help. And really, it's that part is really child led. So usually what happens is a child will come in, hey, what do you want to play with today? We usually have an idea of what they'd liked the day previous, but sometimes they could care less about that. And we have to be pretty flexible with that. So we'll pull out things we know they've liked in the past, but then they lead us to what they want to do. We will oftentimes put those preferred toys on the table to try to encourage and kind of pair like something really fun with the table. And then no surprises. They still know the table we're going to eat. It's not like we're tricking them to get them there or anything, but just making that environment more comfortable, pairing something they know with a newer environment of sitting at the table. And then there's a lot of high fives. There's a lot of praise. I do praise. I know that's pretty controversial. Some people say you shouldn't say good job or anything for eating, but the kids
Well,
that
why
we
not?
see,
If they do a good job, then I will say they do a good job.
yeah, I do too. So I'm a big advocate of that. But there's a whole another school of thought that something like kind of saying good job or praising a child for feeding just adds pressure. So I don't feel that. The kids, if I saw that, I would back off. But the kids that we see really eating is really hard for them. And
Mhm.
when they do actually eat something, I do celebrate that. And you can see it in their faces. They're happy about it. They give the high fives. They start smiling. So I feel that part's important. So that's usually what our sessions look like. We can get into if it does get more challenging. We did have one boy who was really a lot more challenging, and he really tried to kind of escape a lot. And it took a lot more work to get him just comfortable enough with us when he saw the food
Mhm.
to accept some bites. I'll be really honest, sometimes it is really hard. He was a lot harder.
And the boy you're talking about, he has some history, some traumatic history of food training, which was not very comfortable for him.
I agree.
He was the one who was, strapped into a chair and food was pushed into his mouth. So whenever he saw food, it was like
Really hard.
really, really hard.
He did end up doing by the end, though, mom was sending me videos, he was sitting nicely in his seat, and he was feeding himself some yogurt, so it was really rewarding, it was really awesome to see, but he was harder, it took him a lot longer to get comfortable.
That is great progress, him taking on a new food and he actually tried different kind of textures as well. It was one time that we tried the rice cracker with him and he was just happy smearing the rice crackers across his mouth. That was
Yeah,
amazing.
yeah,
Body movements is very important. Sometimes, if we want the child to focus on eating, because movement can also distract the child from taking the bite, then we usually use the first then statement. So first you take the bite, and then continue doing something fun,
yeah,
right?
exactly.
And that would work as well. And sometimes we were able to find something that can occupy their attention for a little bit longer so we could focus more on taking more volumes of food.
Exactly. Yep. Yeah.
When I posted a videos of me giving the child a bite, there would be one or two people who would say, "Well, you're not trained to do this. You're
My
not a feeding therapist." And yeah, I'm not a feeding therapist, but I'm trained in our intensive programs. Kelley is always the one who starts with the first bite because Kelley knows a lot better than I do when it comes to what kind of food to introduce and what kind of tools to use to help the child to take the first bite. Now, Kelley will model that first, and then sometimes Kelley's staff will step in as well to help the child taking some more bite, and I will always be the third one to try that because we want the child to be able to generalize that skill across several providers and people.
I think
Not
that that part's really important. If someone can, like, only eat with Kelly, that's not gonna help them in real life. So I think the more people that can give the person bites or cue them to take a bite or set them up at the table or whatever it is, I think that's really, really important.
I love when you show me the kind of tools you have to encourage
Mhm.
them to even open their mouth, right? I had no idea what to do, how to do because I don't wanna use my hands to
Yeah,
to force the child to
right.
open their mouth, right? But you have
Yeah,
like
we have some really good tools. Yeah, we do.
there's some of the tools I have never seen before. So I just love the fact that I'm able to be in there with you and see what you do in real life. It is very helpful. This kind of
Right.
collaboration, it should be more popular.
I think it's hard to find the providers that are able to do it because when you think about it, it has to be providers that both have experience, similar level, and serves kind of different specialties, like different strengths. And then
Mhm.
we have to have the freedom to be able to work in that way. And a lot of people, even with the best of intentions, just because of employers or corporations, they don't have the freedom to be able to do that. But it would be awesome if they did.
That will be awesome. And I want to explain a little bit too that in our sessions, usually you will be the one who sit next to the child or in front of the child to give the bite. And I'm usually the one who sit behind the child because I want to give them the comfort. Now, if the child needs some squeezing, I can do that. I can observe the environment to see what kind of arrangement I can make to help the child feel more comfortable. Why don't we go to the next part because I think it's also very important. We're going to talk about the part that you are trained in and the part that I am trained in and how we can collaborate.
Yeah, I'd say most trained. I'm in the oral motor piece, how to move food around, how to chew effectively, what to do if somebody gags, because that's a big problem. Like a child will gag, not choke, but a child will gag and then that food is removed. So, how to work through the gag, how to do some coping skills to relax, which I think that's where we cross over quite a bit. And then, if there's any other medical GI issues that might be contributing to their feeding difficulties, I always screen for that and I keep an eye on it the whole time whether it's something like gastroparesis or EOE or something that maybe you don't have as much training in, I'm always screening for those GI issues. So that's the main like bulk of my piece. A lot of the oral motor pieces, a lot of the coping strategies when someone does get anxious, like if you're gagging on a food. And knowing instead of like just removing that food and running away, but knowing how to work through the gag and stay really, really calm and decrease that anxiety.
Hmm.
That's a big part.
We saw some gagging there, especially with the new food. Yeah, and you are right. We do not want to remove the food totally when they gag because then it will train them to engage in that behaviors more often. I come in with the experience in arranging the environment to help the child feel more comfortable. Things that I'm looking for are signs of anxiety, pulling away, running away. I'm watching for avoidance behaviors if the child gradually turn their back towards you. That happens. Most of the time, it is the patterns of behaviors that I'm looking at too. So if you present a food, how do they react to it? If you get the food a little bit closer to them, how do they react? And people don't really see it, but in our feeding session, there's a lot going on. I feel like just one person is not enough because you need somebody there to also observe the patterns of the behaviors as well. Bouncing ideas off each other, I love that. We as professionals, and even though we were trained and we have a lot of experience in our field, there are still moments that we doubt ourselves. We don't have all the answers. I do have moments that I feel like, am I doing the right things? And in those moments, I do really wish that I would have somebody here to bounce ideas off. The girl that we worked at, when we started out, we reinforced her with every bite that she would take. And then after a couple sessions, when she would be okay with taking the bites, then we increased the bite. What I do was thinning out the schedule of reinforcement. So now instead of taking just one bite, now she will have 5 bites. It makes a lot of sense to me. I remember she came in, and the first thing she did with every bite we introduced was to push her tongue out to block the bite. And that seemed so hard. So that whole session was her just pushing her tongue out. And at the end of the feeding program, we don't see the tongue anymore. It's so cool. This is why our collaboration is so important. I think that the takeaway from this conversation is we can collaborate. We should always collaborate. It's helpful in so many levels and so many ways. And I just want people to understand that a feeding therapist should never replace a BCBA, and a BCBA will never replace a feeding therapist or a speech therapist. We are all trained very differently. We have our own expertise, but two brains are better than one, that's for sure. So the reminder here for any parent, if you want to take your child to any clinician, the important question to ask is, are you open to collaborating with other providers? I think that it is a very essential questions to ask.